actually, while we're giving it one more minute, do any of the participants want to introduce themselves? It'd be awesome just to hear where everybody's at and what they're passionate about, what their pets' names are.
I can start. I'm Wendy Chang. I am in faculty at University of Maryland, and I don't have any pets. I always keep wanting one, so I keep go to the SPCA and look for a dog, but have not committed.
Rosny, isn't that how you got Thierry?
Yeah.
You're a better person than I am.
Nah.
Anybody else want to introduce themselves?
Sure. I'm Cindy Bitter. I'm faculty at St. Louis University, and I have a 6-pound poodle named Lola.
Oh,
Cool.
Adorable.
She's very tiny.
That is tiny. My cat is over double his size. Okay, perfect. So I think that we can get started. So first of all, thank you everybody so much for coming to our workshop. It's on how to give an inclusive presentation. My name is Cortland and I'm Vice Director for Diversity, Equity, and Inclusion at Carolinas Emergency Medicine.
My name is Star Knight and I'm an Associate Professor at UCSF and also the Director of Diversity and Inclusion for the Department of Emergency Medicine at UCSF.
And I'm Rosny Daniel. I'm an assistant professor in the Department of Emergency Medicine at UCSF, and I direct our residency education DEI efforts.
Perfect. And we're really excited to give this lecture. It's going to be interactive. If you ever have any questions, just come off on mute or say something in the chat. And we have no disclosures of interest. So first, our learning objectives. So by the end of this talk, we want you to be able to apply at least 5 techniques to make the content and delivery of your next lecture more inclusive. We also want you to be able to identify at least 5 commonly used phrases that are not inclusive. And then lastly, we want you to be able to utilize at least 3 different resources for finding diverse graphics and pictures.
So let's start off by delineating some ground rules. We want to make sure that people feel comfortable engaging, and we want to make sure that people feel included in this session. And so here are a few rules that we have started, but we welcome participation from anyone in the audience. We want people to stay engaged. We want you to be kind and not nice. In the virtual space, we want you to be muted when you're not speaking and respect the space of others. And then we ask that you speak your truth, speak from your own perspective. Are there other rules that anyone wants to add to this to create a brave space and a safe space?
One that I like is it's Vegas. So everything that's said here stays here. Just like Star said, this is a safe space.
I like that one. I also like that you're able to change your mind, that this is a space that we welcome innovation and creativity, and we're going to have discussions about complex topics. Rosny, do you want to say what you just wrote? Oh, okay.
Oh, I'm just referring to the Vegas rules that when you're playing roulette and other games, they say to always bet on black, and it doesn't make any sense, and nothing in Vegas makes sense, but we're going to make sense out of things today.
Okay, perfect. So how are we actually going to get to teaching you how to give an inclusive presentation? We're first going to talk about the actual content of your lecture, and then we'll talk about the content delivery.
And I think that the concept of inclusive is a little bit of an elusive one. We often think of the major parts of our social identities that oftentimes are more obvious. Things like race and ethnicity, gender, maybe ability status, which isn't always obvious, but we want people to think about inclusive as encompassing many different things, right? So that could be, what specialty do you practice in? What's the language that you grew up speaking? Your kind of socioeconomic status, et cetera. So we want people to kind of think of all these different parts of our identity characteristics so that we're thinking of being inclusive of all those things. Now, I think one thing when we do this lecture and talk about these concepts, is we recognize that there will always be ones that we just aren't aware of and that people will introduce us to that happen to be more important to them. And different people have different parts of their social identities that construct who they are, that are more important to them or less important to them at certain times. So just something to be aware of.
Okay, perfect. So like I said, we're going to start with talking about the actual content of your lecture. So many of us had a question like this on our board exams or any sort of exams that we've taken. So you have a 25-year-old Caucasian female, no past medical history, a little bit of shortness of breath, normal O2 sat, lungs are clear, her chest x-ray shows lymphadenopathy at the base of both lungs. So what do people think the answer is? And again, just go ahead and shout it out. There's no wrong answer here.
I was going to say sarcoid, but I'm probably wrong.
It's COVID.
Yeah, it probably is COVID. Diana, you're actually kind of thinking along the right lines. So what if we just made this one tiny change and now we have an African-American female? I think now all of us would really kind of make that automatic association to, gosh, this is obviously sarcoidosis. So what vignettes like this are doing are strengthening our automatic associations so that we associate specific diseases with certain stereotypes, which is fine in itself as a basic premise, but it comes whenever it influences our unconscious bias and leads us to a lot of misdiagnosis.
Let's discuss the hidden curriculum. So in thinking about medical education, we have to, or it's important for us to recognize that we're not simply just transmitting knowledge, that there's a socialization process happening simultaneously, meaning that our learners are also learning our biases. Students are learning from residents, who are learning from fellows, who are learning from faculty, who are learning from more senior faculty. And so it's more than what's just explicitly stated, but many times what's implicitly taught on a day-to-day basis. I think that many of our institutions and many of our departments have mission statements and vision statements that mention keywords like patient-centered care, multidisciplinary teams, and collegiality and professionalism. But when we really step back and think about how we treat one another, how we speak to one another, how we speak to our patients, to our colleagues throughout the hospital, are we really actually embodying these mission statements and these vision statements? So there's always what's listed here, coded language. There's coded language around, especially when during hiring practices and in search committees around pedigree, and there's certain keywords that really imply other things. The use of physical space. I think about one hospital floor at one of the hospitals in our medical system where the surgical floor has beautifully hardwood floors that are buffed, and every other floor doesn't look that nice. And what does that imply about primary care versus surgical subspecialties? There are stereotypes embedded in cases, one of which Cortland highlighted in the previous slide, and we'll go over that. And then in thinking about our own physical gestures, how we interact with our patients, how we interact with our consultants and with different consultants. Who do we give attention to? Where's our gaze preference? What does this say about some of the physical microaggressions that happen on a daily basis? And then lastly, identity-based hierarchies. All of these things are part of a hidden curriculum, which is more than, once again, what is stated, but more so what our students learn. I was just gonna say one other thing is that there's this idea of ethical erosion, meaning that students leave their preclinical years and start their clinical years, and their open-mindedness, their intellectual curiosity, unfortunately fades through that. So this slide goes over a study, the University of Minnesota Medical School essentially examined their curriculum over a 2-year time span, and they looked at the variety of cases embedded in their curriculum. They found that they more frequently involved males in the stems and vignettes of cases more than females, and it had nothing to do with the epidemiology of the disease processes. They also found that they only mentioned sexual orientation in certain situations. So it was rarely mentioned. And when sexual orientation was mentioned, examples that were mentioned essentially reinforce biases, such as homosexuality being mentioned as a risk factor for HIV, or homosexuality being associated with promiscuity or multiple sexual partners. Furthermore, they looked at race and ethnicity, and they found that those labels were used to reference certain cultural or socioeconomic factors, once again playing on implicit biases that are embedded within our medical system and in individuals. For instance, a 51-year-old Jamaican immigrant ended up having HTLV, or a Japanese male businessman with high intake of salt and smoked fish. These are just a couple of examples in one institution that did this. And if we look back at our own medical training, I'm sure we have our own examples.
Okay, so I'm just going to get on my soapbox for a second and just bear with me. So the National Human Genome Research Institute recently released a report, and they basically said that there was extremely little genetic variation among races and actually a lot more variation within the races. So despite this, we continue to use race as a diagnostic tool. I know when I'm signing charts now, I'll frequently see 50-year-old African-American female, and it will have nothing to do with that at all. So doing this really negates issues such as housing, healthcare, nutrition, education, and all of these as sources of diseases. And this is seen in our clinical decision-making rules. So GFR is kind of a big one that there's been a lot of talk about over the last couple of years. So the original study used race-adjusted GFR because they actually said that Black people had higher circulating muscle tissue and therefore higher circulating creatinine. This is obviously not true, and we now know that using race-adjusted GFR leads to decreased admission, dialysis, and transplant for Black patients. Okay, so getting off of my vignette now. So back to the vignettes. So even if the lecture that you're giving is not on anything related to being inclusive or unconscious bias, you can use it as a tool for change. So about 99% of the time, whenever we give an ethnicity, a race, a gender, sexual orientation, it really doesn't matter. So you could either A, not give it, or B, you can use it as a tool for change. So what about presenting a 25-year-old transgender female coming in with chest pain? So doing this not only introduces correct phraseology, but also may open up somebody's mind about the gender spectrum. What about a 20-year-old African-American college student coming in with a headache? What about a 50-year-old heterosexual female coming in with abdominal pain? So I have never had a case presentation in lecture or a resident presenting to me, or I've never presented a patient where I've said heterosexual, because we only say that if our patient is gay. And doing this really only contributes to the concept of heteronormativity. And so if you're going to say it for one group, you should say it for everybody, and you should use it as a tool for change. Okay, so on to a quick activity. So I want everybody to open up the last presentation that they gave. It can literally be anything, any length, doesn't matter. If you gave a lecture for residents, if you gave a lecture for med students, for other faculty, for people not in medicine, does not matter at all. And then I want you to copy down the sentences we have on the left hand. So in the last presentation I gave, different white people made up blank percentage of the pictures that I had. Different Black people made up blank, Hispanic people blank, and Asian made up blank. And then at the end, I want everybody to make their own pie chart similar to the one here on the right. And in doing this, I'm going to kind of acknowledge the bias that this has, because you can never really know somebody's ethnicity or race just by looking at them. For example, you think that I'm white. I'm actually half Black, half white, and so you would probably get that wrong. But just to kind of simplify things. Any questions before we start? Perfect. So I will give everybody about 5 minutes, and then we'll regroup and share.
Hold the same fight that made Martin Luther the king. I ain't using it for the right thing. In between lean and the fiends, hustle and schemes. I put together pieces of a dream. I still we gonna work it out. We gonna work it out. We gonna work it out. I have a dream. I got a dream. One day we gonna work it out. One day we gonna work images of me getting much clearer, dear self. I wrote a letter just to better my soul. If I don't express it, then forever I hold.
I really like looking at how the captions are doing this.
Rap music and the hood play the fatherly role. My story like yours, yo, gotta be told. Trying to make it from a gangster to a Galia role. Red scrolls and stone slaves and Jewish people in cold cage. Hate has no color or.
Oops, song didn't continue. That's okay.
It's gonna come back, I think.
Anybody have any questions as they're going through this activity? There it is. I just needed to click once more. Goodness gracious. Okay, we'll actually end this a little bit earlier, so we'll finish in about 40 more seconds. Okay. Okay. Does anybody want to share what their breakdown was?
Yeah, I'm happy to share. So mine is half white. Let's see, one third black and 1/6 Latinx.
Nice. Anybody else? Thanks so much for sharing.
I was just looking at a presentation I gave, and 10 out of my 22 people represented were non-white. And I think while I was going through it, I was aware of this talk, and some of the graphics I was getting were cartoons. And I think a lot of cartoons often will, like, I try to choose ones that are kind of race, I guess, like neutral, or kind of like a lot of combination shades, just something that I try to be aware of as I'm picking those. But definitely as I'm searching, I noticed that a lot of images are catered mostly towards white people.
Yeah, that's great. I know that I kind of used to use a lot of cartoons. And then I basically was chatting about it with somebody, and one of the residents said, you know, whenever we see somebody who's not obviously of this ethnicity, our kind of unconscious bias just kind of puts them in the white category. So even if the cartoon's like slightly ethnically ambiguous, the person was like, yeah, I just throw them in the white category, which is interesting. But I really just wanted everybody to reflect on their own presentation and to see if it represents the racial breakdown of the US. So this is the data according to the 2019 census. And you can really go through this for any sort of identity characteristics. So what about individuals on the gender spectrum? What about how many individuals that you have that are differently abled? So a person in a wheelchair. What about individuals with different body habituses? So why does it actually matter?
Yeah, exactly. Why does this matter? I'd say similar to what Cortland mentioned earlier around challenging our own biases. We definitely want to do that with ourselves and our learners. But here is a case to exemplify why this matters. What is this case showing? This is a rash. What's the diagnosis for this patient? You can
Yeah.
unmute yourself or put in the chat.
I like the leaning in.
Yeah, I like that too.
Get the magnifying glass out.
I mean, it's hard to tell if it's raised or not, but it's also a unilateral like image, so it makes me wonder if it's a rash that has a laterality to it, which makes me think of like shingles. That, you know, there's a little bit of hyperpigmentation, a little bit of erythema, but you know, this is one of the challenges with derm and, you know, melanated skin, is there are not a ton of resources out there for it.
That's a wonderful point. I like that. I like the thought of shingles. And then we have Dinah in the chat saying blanched and raised, medial to armpit. How about next slide? And you tell me what this diagnosis is.
That's urticaria.
Yeah. So got two people saying urticaria, and you know, this is an example, a clear example of how few melanated images and brown skinned images we get when it comes to dermatologic pathology. And I can, in particular, say that when I'm on shift, I have run into so many cases where learners come to me and saying, I'm not quite sure if this person has cellulitis because they have darker skin. And in regards to why this matters, not only is it important to challenge our own biases when we think about having more images of different types of people in our talks, it's also important so that we can take care of different types of people, right? Regardless of where you're currently training a learner, those learners will go and work all over the country and all over the globe and are going to encounter all types of different patients. And it is definitely going to impact the care for that patient to get the wrong diagnosis, leading to the wrong treatment. Next slide.
Okay, so this is a study conducted from 2009 to 2011 at the University of Washington. They basically looked at all of the slide decks in all of their preclinical courses, and they found that about 40% were female, 60% were male, and about 80% were white people. So just like Star was saying, you know, not having that representation in our clerkships and our clinical learning can really lead to misdiagnosis. So this is seen in so many different diseases, but Lyme is kind of a common example that's given. So white people and people of lighter skin color are frequently diagnosed with the characteristic rash, but people with more melanin and darker skin people, you know, are really diagnosed with the arthralgias in much of the later stages. And that's just because our unconscious bias doesn't really even think about it as a diagnosis, because we don't kind of associate that rash with the diagnosis. Okay, so how do you ensure that your graphics are inclusive? So the first thing is to recognize your own biases so you can actively fight them whenever you're looking for images. So I do that by making a demographic checklist or just kind of pulling up a random demographic checklist on the internet and making sure that I'm representing different categories within it. How do you actually find the graphics then? So
can I just add really quickly, Cortland? I think that oftentimes a question comes up of, can you have this be perfectly balanced? I think the answer is probably no. Not every lecture are you going to represent and perfectly reflect the demographics of your geographic area or the United States or whatever it may be, but at least something to think about and be aware of, and something not just to think about for your one lecture you're giving, but what does my curriculum that I'm developing overall look like? Or if I'm developing a series, how can I kind of just be thoughtful about this as I'm creating it? Sorry to interrupt, Cortland.
No problem. Perfect. I 100% agree. So how do you actually find the images? So you can use filters. So Shutterstock has ethnicity, age, and gender filters. And if you filter out white people, there will still maybe be some white people in your pictures, but they won't be the focus of attention. And then to find pictures specifically of rashes. So there's this great Instagram account by a dermatologist, and then also this book, Essential Dermatology and Pigmented Skin. And then just for more kind of general resources, there's actually an incredible amount of free access resources out there so that you can get different images of individuals from diverse backgrounds. These are some of the ones listed. Because there's so many, we actually created a website that lists all of the resources here, as well as any sort of article that we'll talk about in this lecture. And because a lot of individuals may not have smartphones, another point of mention whenever you're giving an inclusive talk is to always have a link below the smartphone QR code, just because if somebody doesn't have that, they need the link.
Sorry, I was muted. So another thing we think about with these graphics is not just kind of who's included, but kind of how are these folks represented. We talked some about the concept of hidden curriculum, who stands where, who's spoken to, use of physical space, etc. This is just a brief Google search for the word doctor and shows who comes up. You'll notice that it's mostly white people and majority men. And as we look at these next pictures that come up, you'll see that oftentimes the people who are in the frame of focus tend to be men, tend to be white people, and oftentimes the people of color and women are put into the background. So it's not just the content of who's there, but also the composition, the cropping, the lighting. These are things that I know are a little bit hard to think about, understandably, but I think very important to think about. And as we are developing our kind of fast thinking, slow thinking, our type 1 and type 2 cognitive biases that come into play here, we really want to be able to kind of break these things down and use these different types of examples to make it more normal for different folks who may not be your typical representation of a doctor or a patient or this disease process of whoever it may be, to kind of break that down a little bit to allow people to think more critically.
Okay, so the next step, we talked about how to make inclusive vignettes, how to have inclusive graphics. The next is to ensure your statistics are applicable to all. So a few things: if a study occurred in another country, you should mention that and give the population demographics for that country. And then if possible, compare them to the population demographics of wherever your audience is, so that they don't, so that your audience doesn't apply the study incorrectly to their population. You should also mention if there's any particular exclusion criteria, so that your audience doesn't apply that to the excluded group. And in addition to looking at where the study was done, what the exclusion criteria are, it's also important to ensure that there's no hidden association. And that brings us to Stimson's paradox. And I'm terrible at stats, so I outsourced, and here's a video that will explain it.
Isn't just a hypothetical scenario. It pops up from time to time in the real world, sometimes in important contexts. One study in the UK appeared to show that smokers had a higher survival rate than non-smokers over a 20-year time period. That is, until dividing the participants by age group showed that the non-smokers were significantly older on average, and thus more likely to die during the trial period, precisely because they were living longer in general. Here, the age groups are the lurking variable and are vital to correctly interpret the data. In another example, an analysis of Florida's death penalty cases seemed to reveal no racial disparity in sentencing between Black and white defendants convicted of murder. But dividing the cases by the race of the victim told a different story. In either situation, Black defendants were more likely to be sentenced to death. The slightly higher overall sentencing rate for white defendants was due to the fact that cases with white victims were more likely to elicit a death sentence than cases where the victim was Black, and most murders occurred between people of the same race. So how do we avoid falling for the paradox? Unfortunately, there is no one-size-fits-all answer. Data can be grouped and divided in any number of ways, and overall numbers may sometimes give a more accurate picture than data divided into misleading or arbitrary categories. All we can do is carefully study the actual situations the statistics describe and consider whether lurking variables may be present. Otherwise, we leave ourselves vulnerable to those who would use data to manipulate others and promote their own agendas.
Okay.
So how many times have you listened to a presentation and heard a speaker encounter a non-Western name and start to say, I don't know how to pronounce this, but ... they either go on to mispronounce the name, completely butcher it, or don't even attempt to say it. One implicit message that that sends is that that particular culture, that person's background is not important enough for them to learn. And I think one thing we should consider is that if you're making your own slides, that you should be able to pronounce what's in the slides. I think that we all rattle off medical terminology, many of which are complicated words all of the time, like rivaroxaban, methemoglobinemia, choledochilothiasis. And we should show as much respect for people as we do for medical terminology, pronouncing medical disease processes or drugs.
So another example of exclusive language is spatial language. So let's say you're at a lecture and your attending says, as you can see here, and this is basically what it looks like, the board that they're presenting to you. So that's how an individual that's blind feels every time that you use spatial language. So what actually is that? So spatial language in its simplest terms is verbal words that you use whenever you're basically pointing at something. So some phrases are this, that, and these. This is our agenda. Submit feedback here. So if you're ever using these, you should just think about what the message is getting across to somebody who is blind and isn't able to see what this, that, and these are, and you should make sure that you verbally indicate them as well. So now that we talked about exclusive language to avoid, what are some examples of inclusive language? And that brings us to people first language. So this is basically saying, you know, a person has something rather than what a person is. So like I said earlier, rather than saying a blind person, you can say somebody who is blind. Rather than saying somebody who's wheelchair bound, you could say somebody who uses a wheelchair. Some other frequent examples involve substance use. So you should say somebody with a substance use disorder, a person in recovery from a alcohol use disorder.
I think other identity groups that we can be better at with using inclusive language include people from the trans community. We want to avoid transgendered as a term, implying that it's something that happened to someone. MTF, FTM imply that someone was one thing and is now another thing, and that doesn't represent what a trans person actually is or their experience. Terms that are more inclusive are transgender woman, transgender man, transgender male, trans community, transgender community. We often hear euphemisms like inner city and urban when people really want to say Black or African American or representing someone from the Latinx community. When thinking about gender, recognizing that gender is not binary and representing that. So instead of saying both sexes, opposite gender, both genders, more inclusive language would include all genders. Or instead of saying ladies and gentlemen, we can say everybody. And those terms are actually more simple to use.
All right, so we're going to take a look at this video and I'm going to have someone explain what's going on here.
You don't have sound.
Oh, do we not have sound? That brings us to our next part, which is about content delivery. Let's watch this video one more time.
Okay, so the actual content of the video doesn't really matter. The point was that there wasn't any sound. And so that's what somebody would get if they have any sort of hearing disability. So why does it matter? It matters, just like I mentioned, for somebody that's hard of hearing, or if somebody has a learning disability, if an individual learns by taking in information in multiple ways, or if they're in a loud environment. So for example, at home with their kids doing virtual learning and shouting. So it doesn't just apply to videos, but also to graphics. And so let's talk about captioning. So there's a ton of ways to add captioning. So YouTube has its own captioning feature. And again, all of the links here are in the website that the QR code took you to. So if you have a video that's not on YouTube and you wanted to add captions, including captions in other languages, you can use Amara, DotSub, Subtitle Horse. Google Slides also has their own captioning. And then what is this? PowerPoint. PowerPoint has their own, and that's what we're using right now.
PowerPoint.
So there's another reason why subtitles might be helpful, and that's for somebody whose primary language isn't English. And here are some other links for how to change the language of subtitles in different video formats. So far we've talked about the audio aspect of content delivery. The next aspect to consider is the visual aspect of content delivery.
Colorblindness is a relatively common condition. It affects about 1 in 12 men and about 1 in 200 women. There's 3 main types, and you don't have to remember all of the different types specifically. Cortland likes to have me present this slide when we give this talk. And interestingly enough, I'm colorblind. So I recognize that on the slide that we are showing, there is some kind of difference on the 2 sides. I can't tell it all because I'm red-green colorblind. So there's some ways to work around this and make this more accessible to folks. So one such thing you can do is just avoid certain patterns like green, brown, green, blue, blue, gray, in color font with a bold color background. Most of the kind of pre-created formats and slide types that you can get on PowerPoint, Google Slides, those types of things typically do take some of these things into consideration and usually have a color palette it's a little easier for folks to digest who have all different kinds of kind of color processing differences. But there's some pretty cool spaces that we can use, like a contrast checking website or the Bright Slide app, which help to review your slides and can make kind of auto suggestions to help you change the color content of your slides to make it more visible.
And the Bright Slide app is really cool because basically once you use one of the other contrast checking or color checking websites and it tells you that this particular color of green is not great to use, you can then use the Bright Slide app and just select that color of green once, and it will go through and automatically change it for your entire presentation. So it takes what would have taken a ton of time and makes it a lot easier.
And lastly, there is the opportunity to see what it would look like to someone who is colorblind if you use one of these websites like Color Oracle, Sim Daltonism, or Coblis, if you're curious and still wondering and making sure that your pictures and slides kind of make sense. Some other ways around this, instead of just using these apps that we mentioned, you go to the next, oh, there we are. So you can use things like texture, which makes it a little bit easier. So on the slide that we're presenting here, there's some different colors, but also represented with different types of textures like dashes, dots, and dashes, which makes these things a little bit easier to distinguish from each other and don't just rely on color.
So transitioning from color visual aspect to thinking about participants that are listening to your presentation and reading your presentation and may have dyslexia. A couple of tips to help them process the information you're trying to get across include changing your fonts to familiar fonts, such as the ones listed here, like Arial, Calibri, Sans Serif. Using small blocks of text and spacing out your text. You can space out to 1.5 spacing and left justifying your alignment. Next slide. Things to avoid would include cursive, condensed fonts, starting a sentence at the end of the line or the right side of the page, all capital letters or excessive italics, and then avoiding bright white backgrounds. And even in the slide deck that we presented, we have some softer whites, or really more like grays to offset glare, but really avoiding that very bright white.
Okay, so the next aspect of content delivery to consider is mobility. So whenever you're planning activities, it's really important to not alienate anybody with different mobility needs. So it may be hard for somebody with obesity to easily get around a very small room filled with chairs. It might also be hard for somebody in a wheelchair to navigate a room for an activity if the room has a lot of steps. Along kind of those same lines, you should really ensure that your room setup, and this is whenever we're not doing virtual learning, so who knows whenever that will happen, is accessible to all of those with different mobility needs. And a person with a wheelchair, for example, shouldn't have to sit in the back of the room. So in each of these pictures, it's pretty obvious what the person's different mobility needs are, but oftentimes it might not be that obvious. And so it's important not to assume that everybody is going to be physically able to do an activity. So the last aspect that we're going to talk about for content delivery is neurologic considerations. So this is something that I hadn't previously talked about before preparing for this presentation. So it's important to avoid bold, flashing slide transitions, strobe or flashing GIFs. So at their best, they may make individuals feel like they're at a rave that they didn't sign up to go to. And at their worst, then actually trigger nausea, headaches, dizziness, and even seizures. So about 3% of individuals with epilepsy have photosensitivity epilepsy, and that's where their seizures are triggered by these visual exposures. So one thing that can trigger them are flashing lights followed by darkness. Another is certain patterns such as stripes. And I was actually curious to see what it is about these actual visual triggers that cause the seizures. And I found that for some, it's the intensity of the light source. For others, it's the amount of visual field that's actually occupied by the flashing objects. And then for stripes, it actually depends on how many stripes are in the visual field. So there is this Pokemon episode. I don't watch Pokemon, but I read a lot about this one. So there's this Pokemon episode where Pikachu blocks a vaccine missile with a thunderbolt attack. And then there's this explosion. And apparently whenever this was aired first, about 700 kids were taken to the hospital for headaches, seizures, dizziness. Nintendo stocks fell about 5% the next morning, and the episode has actually never been aired on TV again. I tried to find it and I was not able to find this episode. So it's really important just to consider, things that you wouldn't really think about. Okay, so quickly to summarize. So first we talked about how to make the actual content of your lecture more inclusive. We talked about using your vignettes as a power for change. So if you can counteract somebody's implicit bias against the transgender community when giving a talk about fascia iliaca blocks, that's a great plus. We also talked about using diverse graphics and images and paying attention to not just who you have in them, but also what message you're sending with the composition, the cropping, and the lighting. And we talked about where to find those images. We touched on avoiding exclusive language, such as spatial language. And then we talked a little bit about inclusive language, such as people first. Next, we talked about content delivery, specifically the importance of captions and where some different captioning software are, how to optimize your presentation for somebody that's colorblind. And we talked about selecting a color palette via a website such as Color Brewer and testing it via a website such as Cobliss. We talked about using familiar fonts for somebody with dyslexia and using left justified spaced out text. And then lastly, we talked about mobility and neurologic considerations. Here are our references. And again, here is the QR code. The link is https://tinyurl.com/YY45YAOB. Anybody have any questions? Thank you all so much.
I put that in the chat one more time as well.
That was really great and very inclusive, because I think I came into this lecture thinking, okay, I'm going to learn to be a little bit more inclusive in terms of whether it's race and gender, etc., but a lot of other things that I never considered before.
Yeah, I know before preparing for this talk, I'd never had a picture of an individual in a wheelchair, for example. Literally never, despite that being, 20% of the people that I see on a regular shift in the ED. So it just kind of brought up things that seem so obvious, but really aren't. Any other thoughts?
I think that Dinah and I are looking at our slide deck for tomorrow and going, shit.
I have done that also a lot. Any other comments? Perfect.
I want to say
Great, thank you.
thank you for your attention and staying engaged. We recognize that Zoom fatigue is real and this entire conference is virtual. So thank you for staying engaged.
Thank you all so much. We really appreciate it. And we can put our emails in the chat. Rosny, are you able to put our emails? I just volunteered that for you guys.
Cortland, yours is Cortland Brown at Atrium Health.
Portland.Brown. But I actually just learned that the dot doesn't matter, and that blew my mind.
Atriumhealth.com.
Org, I think. Yeah.
Yeah, thank you for coming.
Thank you all so much. Okay, I hope everybody has a great day.
Thank you so much, Al.